in a quest to find the cause of severe anemia, a granulomatous conclusion. So, this is a 16-year-old developmentally normal girl, born of non-consanguineous marriage, immunized up to date, was brought to SRMC on 4th July 2021 with history of amenorrhea for past 6 months, severe pallor, left ankle joint pain and swelling, and left hand pain and swelling for the past 2 weeks. Past history, child was apparently normal till December 2020, and from 2nd January, the child presented to a hospital elsewhere with history of fever with arthralgia, cough, weight loss, lethargy, and fatigue for 6 days. Fever workup was negative, including COVID-19. Chest X-ray done at that time showed bilateral middle and lower zone infiltrates. Symptoms didn't subside, hence child was taken to a pulmonologist elsewhere. And CT scan done showed large consolidations with air bronchograms and multiple air space-filled nodules in bilateral lung lobes, and with no mediastinal lymph nodes or pleural effusion. So they interpreted it as suspecting infective etiology, suspecting pulmonary TB, and in view of ground glass opacities, Corax 3 was suspected, and child was started on ATT from 13 January 2021 under RNTCP guidelines with clinical and radiological diagnosis. So end of April, child continued to have fever with myalgia and arthralgia, and child turned out to be COVID-19 RT-PCR positive. Child was home isolated and was symptomatically treated, and child was afebrile within 3 days. End of May, continuously the child had fever spikes and cough, and child was taken to a multidisciplinary hospital elsewhere. This shows a periodic blood investigations showing continuous fall in hemoglobin. Initially it was 7, but later on it was 4.4 with elevated ESR and CRP. In outside hospital elsewhere, the complete blood picture showed hemoglobin of 3.9 with other normal total counts. Reticulocyte count was normal. DCT and it was negative, and LDH was normal. Stool for occult blood was negative. LFT showed hypoalbuminemia. Urine routine showed protein of 3 plus with microscopic hematuria, RBCs of 8 to 10, with spot protein creatinine ratio of nephrotic range 3.72, with normal RFT and serum electrolytes. Imaging, chest X-ray, ultrasound abdomen, and 2D echo were normal. So they considered a diagnosis of severe anemia, suspecting autoimmune etiology, SLE, and they have given symptomatic management, packed red cell transfusion, and ATT was continued. As autoimmune etiology was suspected, ANA done hospital elsewhere was positive in 1:320 dilution, and dsDNA was equivocal, where C3, C4 levels were normal. Child was discharged with oral and, iron and calcium supplements, and discharge hemoglobin was 6.4 grams per deciliter. On 8th June, child had abdominal pain, was taken to hospital elsewhere, and urine routine showed proteinuria and microscopic hematuria. And spot urine protein creatinine ratio was 1.18. So child was referred to SRMC as the child had persistent proteinuria and microscopic hematuria with normal RFT and serum electrolytes. This shows a trend of serial urine routine examination, which showed persistent proteinuria and microscopic hematuria with nephrotic range spot protein creatinine ratio always with normal RFT. So the child was brought with a pallor, left ankle joint and left hand pain and swelling with amenorrhea for past 6 months. On examination, vitals were stable, pallor was present with no lymphadenopathy. Systemic examination was normal, with local examination showed tender erythematous joint swellings. So a provisional diagnosis of suspected autoimmune disorder or suspected tuberculosis, anemia of chronic disease, and lymphoma was also suspected. So initial investigations done on 4th July showed microcytic hypochromic anemia with hemoglobin of 5.4 with elevated ESR, hypoalbuminemia, proteinuria 3 plus, and microscopic hematuria with other normal blood parameters. Anemia workup revealed low serum iron and elevated ferritin with other workup normal. Autoimmune workup, ANA, dsDNA, extractable nuclear antigens, complement levels, lupus workup, serum ACE levels, and anti-CCP were negative. Lymphoma was considered as the child had painful joint swelling and anemia, which showed uric acid elevated, serum phosphorus was also high, and other electrolytes were normal. So we proceeded with bone marrow biopsy and aspiration to rule out malignancy. Bone marrow biopsy showed a normocellular pattern with trilineage hematopoiesis, and the impression was just reactive marrow. So we proceeded with PET CT. So PET CT showed diffuse ground glass opacities of bilateral lung fields, multiple FTG-avid nodules with cavitation bilateral lung fields, and enlarged FTG-avid lymph nodes in perihilar and paratracheal, lymph nodes with SUV max of 3.20. So impression was suggestive lung features in favor of infective or granulomatous etiology. To rule out infective etiology, we went ahead with infective workup and did bronchoalveolar lavage. And bone marrow aspirate samples were also sent for AFB and gene expert for Mycobacterium tuberculosis, which were negative. Bronchoalveolar lavage samples were sent for fungal, bacterial, tuberculosis, and cytomegalovirus were negative. Bronchoalveolar lavage cytology showed diffuse alveolar features suggestive of diffuse alveolar hemorrhage. So workup, we went ahead with renal biopsy. 24-hour urine protein was 4,600 mg per day. And ultrasound guided renal biopsy showed crescentic glomerulonephritis favoring posse immune associated necrotizing glomerulonephritis. Meanwhile, the proteinase 3C ANCA by immunofluorescence was positive by 1:10 dilution. This is a microscopic slide showing immunofluorescence of the child, which is highly positive. And quantitative ANCA by ELISA titers were very high, more than 200 relative units per ml. So less than 20 is normal, more than 200 is highly positive. So the final diagnosis was granulomatosis with polyangiitis. Child was started on high-dose methylprednisolone for 3 days and was tapered to oral steroids. Cyclophosphamide therapy was initiated with Mesna and was planned to give for 6 cycles. Discussion: granulomatosis with polyangiitis is an ANCA-associated vasculitis, is a group of disorders characterized by inflammation and destruction of small and medium-sized blood vessels and the presence of circulating ANCA. Clinical disease phenotypes include granulomatosis with polyangiitis, microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, and renal limited vasculitis. ANCA-associated vasculitis has a predilection for the kidney, with more than 75% of patients having renal involvement characterized by rapidly progressive glomerulonephritis. Coming to epidemiology, it is very rare in children. The reported annual incidence rate from a Swedish study was 1.4 per million children. And childhood ANCA-associated vasculitis has higher female preponderance, with peak age at onset in the second decade and median age at diagnosis of approximately 12 to 14 years. So this is a Euler-Press criteria for childhood granulomatosis with polyangiitis, where 3 out of the following 6 criteria should be present. In our present index case, we had 3 criteria. Pulmonary involvement was there with PET CT showing nodules, cavities, and infiltrates. ANCA was highly positive by immunofluorescence, and renal involvement was there showing necrotizing posse-immune glomerulonephritis with persistent proteinuria and microscopic hematuria. So this is a Euler-Press classification for ANCA-associated vasculitis. It is basically divided into large cell, medium vessel, and small vessel granulomatous vasculitis. So large vessels include aorta and its major branches. Medium vessels are the main visceral arteries and veins and their initial branches. Small vessels are intraparenchymal arterioles, capillaries, venules, and veins. So when to suspect vasculitis in a child? Fever with or without rashes, weight loss, fatigue, myalgia, anemia with thrombocytosis, raised ESR, and multi-organ manifestations, we should suspect vasculitis in a child. So these are the manifestations. Large vessel shows absent pulses, bruit, hypertension, BP discrepancy, cardiac failure, cardiomegaly, and claudication. Medium vessel vasculitis shows hypertension, abdominal pain, libido reticularis, focal deficits with gangrene and orchitis. Small vessel vasculitis shows purpura, superficial ulcers, mucosal ulcers, pulmonary and renal syndrome, ENT disease, asthma, and eye manifestations. Take-home messages. Vasculitis should be considered in children presenting with features of multisystem involvement. Vasculitis should be considered in the differential diagnosis of children presenting with atypical chest findings and other organ involvement like kidney involvement showing proteinuria. Extensive investigations may be needed to rule out other causes like tuberculosis, fungal and viral causes should also be ruled out when atypical chest findings are present in imaging, and aggressive management is required to bring the disease under control. Thank you for giving me this opportunity.